further ado, we'll start with our first speaker, which is Rick Wiggins. He's from the University of Utah, and he's going to school us in some temporal bone anatomy. Rick.
Okay, good morning. Let's test this. So I'm Rick Wiggins. I'm from the University of Utah. For this session, you can see the URL at the bottom. You should just be able to open your web browser and go to that web page at the bottom and log on. We do have ribbons for the winning team. You should be automatically assigned to either the Bulls or the Bears, And the winning team can all have a ribbon at the end if you win. And the top 3 scorers, if you're interested, we have lovely trophies up here for you that Dr. Shatskis will be handing out at the end. We do have a streaming audience. So if there are any questions from the streaming virtual crowd, we may try to address those as we go along. So I'm going to start off the show with temporal bone. Dr. Phillips is going to talk about skull base, and then Dr. Curtin is going to talk about larynx anatomy. So I have nothing significant yet to disclose to you. I'm not yet comfortable with all of you to tell you things. But we're going to be looking at anatomy. So we'll talk about the important anatomy of the temporal bone, have discussed some of the nervous structures, and review the important imaging anatomy of normal anatomy of the temporal bone. There will be some questions here. Some are touch questions. I'll try to tell you when they are, and some are just choices. You should be able to tell on your device if you're logged on which they are. So I'll try to tell you. There are obviously right and wrong answers. As we live in our new world of right and wrong, we know who the winners and the losers are now. The important thing here is that it may not necessarily be what you think is the right answer, but what I think is the right answer. So you have to think about what would I do necessarily in this situation. So the important thing here is what would Wiggins do with this question. So as much as it may scare you to try to think about that, like other scary things, President Trump, we'll try to go, sorry, too soon? Okay, so we're going to go through some anatomy first of the temporal bone. I'll have some questions smattered in. Some are easy, some are hard. I will try to make them harder by going fast and not giving you very much time to answer the questions. So this is a rapid fire diagnosis live session. You'll have to answer quickly if you want those points and to get the special big pointy trophy at the end. So we're looking at the skull base. There are a lot of ways to think about this, anterior, middle, and posterior cranial fossas. I'm going to focus in, though, just on the temporal bone. We have some very complex anatomy that we'll be going over here this morning. And if you think about it inferiorly at the skull base, again, we have all these important cranial foramen. We'll review some of those. I'm just going to be focusing, though, on the temporal bone in this area here in red off to the side. Dr. Phillips is going to be talking about the rest of the skull base. So I'm going to start from the outside and go in. And in the interest of time, we're just going to think simplistically about some of the big important anatomy regions and areas that we look at. So we'll start with the EAC, then look at the middle ear, and then look at some of the inner ear structures and some of this subtle anatomy and try to differentiate who the winners are here in the crowd. So we'll start with the EAC itself. So laterally we have fibrocartilage portion, and then we have an osseous portion medially and extends over to the tympanic membrane. So we have some important anatomy that goes medially. So what is the name of this structure? So we have 223 people signed up. If anybody's having trouble registering, getting the website, you should be able to put in that URL that you saw at the bottom. 58 have answered, 59, 65. Come on, get up there. Click on something. It could be any of these answers, I don't know. Some of you are slow answerers. Okay, 68% tympanic annulus, that's right. Ring of curtain. 5% said ring of curtain. Dr. Curtin's happy about this. So laterally we have fibrocartilage portion, medially we have osseous and extends up to the tympanic membrane. The tympanic membrane goes from the scutum or shield down to the tympanic annulus. That's that inferior portion, inferior attachment of the TM itself. Important drainage, the pinna of the ear and the periauricular skin. The first nodal order drainage station is to the parotid. That's where the lymphatics are leading. So we want to remember that important anatomy there. So our TM is extending there. So we see here the scutum or shield up high and the tympanic annulus down low, the inferior attachment. So it is at an angle going down in our EAC. And the skin is constantly trying to be cleared. And we take Q-tips and we shove that skin back in. So if you take a permanent marker and you put it in your ear and you make a little dot in the middle of the tympanic membrane, don't do this. You put a dot in the middle, that dot kind of becomes a circle and clears out the EAC. So that skin is constantly trying to be cleared out through there. And the top of the TM has a little part we sometimes refer to as pars flaccida, and the rest is mostly tense portion. The pars flaccida is where we get retraction pockets of cholesteatoma, and that's where they occur. So on the other side of the TM is our middle ear cavity. So this is a touch type question. We're looking at a coronal CT of the middle ear. Where is the epitympanum? So touch on where the epitympanum is. You should see a little blue target, and then click on submit there on the bottom. 21, 43. Do, 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 do. 160, okay, close to you've answered. Whoa, all over the place. So the correct answer is outlined here in yellow. I don't know, who is this, seriously? Which one do you got? Come on, raise your hand. It was you, wasn't it, Brian? Oh, God, horrible. So these touch type questions are great. We see where everyone in the audience answered. So the epitympanum is the top up here of the middle ear cavity. So we could think about it in different portions. If you hear anybody refer to the epitympanum, the mesotympanum, and the hypotympanum, those are the different portions of the middle ear cavity themselves. If we look at a coronal of the middle ear cavity and we think about where the scutum or shield is, the superior attachment of the TM, if we draw a line from there over to the tympanic segment of the facial nerve, that's going to separate for us these areas on top and bottom. If we draw a line straight over the floor of the EAC, that's going to separate for us the epitympanum on top, the mesotympanum on bottom, and the hypotympanum down on the very bottom. So epitympanum, mesotympanum, and hypotympanum in that area. So we can think about the middle ear cavity as this three-dimensional box. So anteriorly we have the temporal fossa, posteriorly we have all the mastoid air cells, superiorly is the roof, the tegment tympani, inferiorly you have the jugular foramen, laterally we have the TM, and then medially you have the otic capsule and the cochlear promontory, the bump that is over the cochlea itself. So this is the otic capsule, densest bone in the body, should be bright white all the time around the cochlea and the vestibule in those structures. So we're in the middle ear. How many ossicles are in one middle ear? It's not a trick question. Some of these are easy, some are hard. Answer fast if you want the big trophy. Get in. I'm going to move along. I'm going to say something. How many of you will say 0? Come on. 95% said, oh, some of you did say 0. Wow. So one smart ass in every class. Sorry. So 95% said 3. There are 3. So here's the stapes that we see medially. So if we're inside that box that is the middle ear cavity, and we look medially, we see the cochlear promontory. This is a eustachian tube, so I know this is anterior, this is posterior. Here we see the stapes going up to the oval window. And if we look around the other direction, we see the tympanic membrane attachment. Here's the eustachian tube, so now I know this is anteriorly. And I see the attachment of the manubrium at the little indwelling called the umbo at that location. Goes up to the long process of the manubrium and the malleus, goes up to the head of the malleus, and then the incus goes back. So if we do have a perforated eardrum, we see the malleus, the incus, and the stapes going up to the oval window. So they're all held together in one place in the middle ear cavity. How many suspensory ligaments are normally found within one middle ear cavity? How many suspensory ligaments are in one middle ear cavity? Some of you are refusing to answer. Got to answer fast. Rapid session, diagnosis live. Sit down, log in. What are you doing? Is coffee that important? So most of you said 4, big variety. C, so a lot of you said 2. There are usually 4 that are seen on here. When we think about the temporal bone, every time we look at axial temporal bone, we want to see a nice ice cream cone. The scoop of ice cream is the head of the malleus. The cone is the short process of the incus. There are 4 suspensory ligaments that are normally seen holding these in place. If we think about the ossicles, the important part is the ice cream cone. So it makes sense that all these suspensory ligaments are around there. The important part of the ice cream cone is the scoop of the ice cream. So we have 3 suspensory ligaments going to the malleus and 1 going to the incus. So there's one going superior from the head of the malleus, that's the superior one. There's one going anterior from the head of the malleus, that's the anterior suspensory ligament. There's one going lateral from the neck of the malleus, so that's the lateral ligament. And then from the back tip of the cone back to the fossa incudus in the back, there's one suspensory ligament in the back, that's the posterior one. So there's normally 4 suspensory ligaments that we think about holding these ossicles all in place in suspension in the middle ear cavity. So, and the epitympanum and the roof again, if we draw a line from the tip of the scutum over to the tympanic segment of the facial nerve, above that is the epitympanum, that's where the ice cream cone is. The ice cream scoop is the head of the malleus, the cone is a short process of the incus. The space between the head of the malleus and the scutum is often referred to as Prusac space. That's technically what the guy, it's not actually what the otologist named Prusac described. He actually described the space between the top of the TM and the neck of the malleus. But we often call the lateral epitympanic recess the space between the scutum and the head of the malleus. And that's where a pars flaccida retraction pocket cholesteatoma often occurs. So we look for soft tissue at that location between the scutum and the ossicles, pushing the ossicles medially when we're thinking about a pars flaccida cholesteatoma. And if you hear the phrase COG, there's sometimes an anterior septation at the level of the ice cream cone, and that is a good surgical landmark. That COG is that anterior air cell. So we also have, possibly, some muscles holding the ossicles in place in the middle ear cavity. So how many muscles are there that connect to the ossicles? $148. There's like 100 of you who are not answering. Why will you not play with me? I don't understand. Is it too early? Not enough coffee? Okay, so majority of you, over half, said 2. That is correct. There's 2. So here's that perforated eardrum view. We've removed the TM. We're looking through the canal. We see the long process of the manubrium, the malleus going up, and there's the little tensor tympani muscle that's innervated by V3, the mandibular division of V3 as it comes down. And then we have the stapedius muscle that's innervated by 7 that goes to the stapes. So we have 3 ossicles. We have 4 suspensory ligaments. And we have 2 muscles that are holding these ossicles in suspension, like an art installation, in the middle ear cavity itself. So there's some important anatomy in the back wall. One is the sinus tympani. So where is the sinus tympani on this picture? If you have to, you can click on the little top 3 lines if you need to sync, if you're not seeing the same slide that I'm seeing. So this is another touch image, so touch on the image where you think the sinus tympani is, and then hit submit on the bottom. You have to submit to me. Go ahead, hit submit. 165. Come on, we're good. Okay, I can't wait all day. We're good with that. Whoa. Okay, so sinus tympani is this important area of the back. God, who is this? Come on. Raise your hand, seriously. One of you guys. There's one in every class. So we have all these dots here where this is the sinus tympani, this important area in the back wall. If we think about the very back of the mesotympanum, the middle part, there's these important structures in the back wall. Near the descending or mastoid segment of the facial nerve, there's a little recess, so that's the facial nerve recess. There's kind of a bump next to that medially, shaped like a pyramid, so that's the pyramidal eminence. That's where we think about that little stapedius muscle coming off and going to the stapes. And we think about the area from the pyramidal eminence over to the windows as the sinus tympani. These are important areas, again, with cholesteatoma. It's hard for the surgeons to go through the EAC and make this sharp turn to look at that very back wall, to look at that subtle anatomy. So this area back here is called the sinus tympani between the pyramidal eminence and the windows. We think about that anatomy in that area. So we have these ossicles, the malleus, the incus, and the stapes, all suspended within the middle ear cavity. Here they are all separated. So we have the long process of the manubrium of the malleus. That's going to connect to the TM. It goes up to the head of the malleus. That's going to connect to the short process of the incus. Long process goes down, has a little hook on the end. That connects to the stapes superstructure that has an anterior and a posterior crura. So this is how they all connect. So we have some big physics going on here, mechanical dynamics, with the big surface area of the tympanic membrane to the very small attachment of the TM, going up to the head of the malleus, to the incus, again a small surface area at the superstructure of the stapes, and then a larger surface area at the oval window itself. So here's a graphic in a real otoscopic view. We like to see that long process of manubrium of the malleus, a nice light reflex, and we think about a nice intact TM. If we do have a perforated, we can sometimes see those ossicles within the middle ear cavity. And here's a nice case where we have a big perforation of the TM, and you can actually see these structures. So there's that long process of the manubrium of the malleus. Here's the long process of the incus coming down with the little hook, and you see the posterior and the anterior crura of the stapes as it goes over to the oval window, and here's that cochlear promontory below it. So in a patient, if they have a big eardrum perforation, we can actually see these ossicles, those muscles, the nervous structures, and the suspensory ligaments. So on imaging, on coronal, we think about that long process of the manubrium going up to the head, and then as we go back, we see the long process of the incus going down, has a little hook on the end, of the stapes going up to the oval window. So on the coronal, we like to see a nice duck head on all those views. So same thing on axials. We start with the long process of the manubrium of the malleus going down, attaching to the TM. So we can follow that line coming up. That's going to go up and connect to the head of the malleus as we go superiorly. So on every axial CT of the temporal bone, I want to see a nice ice cream cone of the ossicles. So the head of the malleus connects to the short process of the incus, and we can then follow the long process of the incus as it goes down, has a little hook on the end that connects to the stapes superstructure, and we see the anterior and the posterior crura of the stapes. We want to be able to see those well on our CT scan, and we want to get thin enough cuts so that we could differentiate the anterior and the posterior crura. If we see them too well, we're sometimes suspicious of something like long-term infection like tympanosclerosis that may be scarring and holding those down. But if we can see both the anterior and crura well, we think that they're a well-done CT. So epitympanum, that's where the ice cream cone lives. Mesotympanum, that's the middle. That's where the stapes live and the long process of both the malleus and the incus. The hypotympanum is very boring. There's just air there, except when it's very exciting. Because immediately below the hypotympanum, we have the carotid and the jug. And if either of those are extending up into the middle ear cavity, that can get exciting very quickly if you can imagine somebody going in and think that they're biopsying a vascular mass behind an intact tympanic membrane in a patient with pulsatile tinnitus. So those are the three parts, the epitympanum, the mesotympanum, and the hypotympanum at that location. So that's the EAC in the middle ear, and we're going to finish up with the inner ear and the nervous structures that are around them. So the inner ear structures, we have the bony labyrinth, or the otic capsule, the very dense bone that's around the membranous labyrinth, the fluid-filled structures. This is densest bone in the body. It should be bright white all the time, all the way around these structures. If it's not, we're thinking about the range of pathology that can happen there. We want to see the fluid density on CT or intensity on MR within the otic capsule in those structures. And these structures are all adult size and formed in pediatric kids. If you look closely at pediatric heads, it looks like those inner ear structures are huge and the rest of the head is growing around them. So we have the cochlea, hearing, we have the vestibule and the semicircular canals, our balance, and we have two little aqueducts, the vestibular and cochlear, and we think about these as little channels, potential routes of spread of infection from intracranial disease into these structures. So again, otic capsule, densest bone in the body, and then the membranous labyrinth, the fluid-filled structures that are inside. So here is the cochlea, hearing anteriorly with the cochlear nerve. Here is the vestibule and the semicircular canals. So we have these three semicircular canals, superior, lateral, and posterior, and they're all oriented 90 degrees to each other. So we can think about them like the corner of the room where the ceiling meets the walls. They're all oriented that way. And one on one side is exactly opposite 90 degrees from the other. So if we close our eyes, we can still tell that our head is turning because one is excited and one is inhibited, amputopedal and amputofugal, from the little otoliths, the stones that are within the ampulla of each one. So in the coronal view, we want to see a nice duck head on every CT. Again, on every axial CT, we want to see a good ice cream cone. On every coronal CT, we want to see a good duck head. Head of the duck is a vestibule, beak is a lateral semicircular canal, and the neck is going down to the basal turn of the cochlea. That's important anatomy, and there's a big range of incomplete partitions and dysplasias as well as hypoplasia that can happen to those inner ear structures. So we can think about the canals and all the fluid that connects these with the membranous labyrinth, these structures that are inside of the otic capsule. And we think about the perilymph and the endolymph, the fluid that's inside of those. So this is a picture where we just have the fluid. So each of the semicircular canals has its own ampulla. a little swelling where we think about those little otoliths in that position that help us with our balance. In the cochlea itself, we have these different chambers. We have the modiolus, the bow tie in the middle of the cochlea, and these three main chambers that we discuss in the cochlea. The top of this one is flat like a tympanic drum, so that's scala tympani. This one is kind of shaped like a V on top, so that's scala vestibuli. And this guy is in the middle, so he's scala media. We have the little basilar membrane or organ of Corti, if you like to name stuff after dead people, on there with one inner and three outer rows of hair cells that we think about within the cochlea itself. That's going to vibrate maximally somewhere along the 2.5 or 2 3/4 turns of the cochlea. Those neurons go to the spiral ganglia that populate the modiolus, and they come together to form the cochlear nerve. And we can almost see these on imaging. It's a very exciting time. So here's that modiolus, the bow tie in the middle of the cochlea, and we're almost getting to the point where we can hallucinate these chambers and this vestibular membrane, or Reisner's membrane, that separates those different chambers. So if we take the cochlea and we unroll it and roll it all out, we have these fluid-filled structures. So if we unroll the cochlea in one long flat space, we have the scala media with this fluid chamber in the middle. That's technically endolymph. And then the red here is the perilymph around the outside. So in this picture, we could think about scala vestibuli on top, scala tympani on bottom, and scala media kind of in the middle. And the scala vestibuli, that's going to be where our oval window is. And on the scala tympani is going to be our round window. So at the oval window, that's going to be where the stapes is connected. So we have the stapes pushing in and out. So the oval window goes in as a round window goes out. And we have fluid dynamics going through this structure. You see how those different chambers, scala vestibuli and tympani, are actually connected at the top apex of the cochlea. And we also have mechanical dynamics going immediately through the scala media. So that's our sound function. So we think about those airwaves. So my diaphragms contract. It pushes air out of my diaphragm. My vocal cords go back and forth. My oral cavity changes shape to form words. Those sound waves get directed by your pinna into your EAC. That moves the TM. That's going to move the manubrium of the malleus force. That moves the incus. That moves the stapes. That pulses back and forth there at the oval window. Oval window goes out while the round window goes in. And we can think about the dynamics and the physics of going in at the cochlea itself. So if we kind of zoom in of the cochlea, we have these different frequencies. We think about high frequency at the base and low frequency up at the top. And somewhere along those turns, usually it's 2.5 or 2 3/4, but sometimes it's 3 turns, sometimes it's 2 turns. We don't judge, everybody's equal. But when we think about that basilar membrane and the 1 inner and 3 outer rows of hair cells, that's going to vibrate maximally somewhere along that course. Those little hair cells are going to move back and forth, and those neurons are going to go to the spiral ganglia that populate the modiolus. They're firing off, and that is transported to our nuclei in our midbrain. It crosses over to the other side and goes up to the auditory cortex, and that's where our hearing center is there of the brain. And even though I talk pretty fast, you can understand a very small percentage of what I say because the system is working the whole time. It seems extremely complicated. So then we have 2 big nerves we'll finish up with. So first is the 8th nerve, the vestibulocochlear nerve. So again, we have all these different chambers, scala vestibuli, scala media, scala tympani. That's where our organ of Corti is with the 1 inner and 3 outer rows of hair cells. Those neurons go to the spiral ganglia that populate the modiolus, the bow tie in the middle of the cochlea. They coalesce together to form the cochlear nerve, and the cochlear nerve goes through the cochlear nerve canal into the internal auditory canal. So that's the cochlear nerve. Now in the back we have the superior vestibular nerve. How many branches does one side of the vestibular nerves divide up into normally? There is a little bit of variability here, but when those nerves go out laterally, they divide up into different nerves. How many terminal branches do you think they are? I'll give you a hint. The vestibule is made up of 2 big structures, the utricle and the saccule. He said sac. 185, 190? Okay, what do we say? Ooh, small percentage you got. So most of you said 2. So there is the superior and the inferior vestibular nerves in the IC, but if you look closely, we can actually see sometimes little canals in the lateral IC as these nerves divide up. And there's actually 5 different nerves that are kind of the terminal branches. We have 5 main structures out laterally in our balance or vestibular system. The vestibule is made up of 2 components, the utricle and the saccule. And then we have 3 semicircular canals. Each one of those has an ampular swelling. So we have 2 nerves going to the utricle and the saccule, and we have 3 nerves going to each of those ampulla. So there's 5 different nerves laterally. We think about the superior vestibular nerve dividing up and going to the lateral and the anterior semicircular canal ampulla, as well as the utricle, and the inferior one going to the saccule and the posterior ampulla semicircular canal. So we have 3 semicircular canals, each one has an ampulla, and then we have the vestibule that's made up of 2 parts, the utricle and the saccule. So there's 5 different things there that we think about nerves going to with those vestibular nerves out laterally. So in the IC, if we do a sagittal cross-section through the midpoint or within the lateral IC, we see division of these nerves into 4 different nerves. This is a touch question. So touch on which number you think is the facial nerve. One under. Ah, good division there. So this is the internal auditory canal. This is the cerebellum, so I know that's the back. This is posteriorly. So this is anterior, this is superior, and this is inferior. Oh, so close. So when we think about that, we think about where the posteriorly, the superior, the inferior vestibular nerve, and we remember it as 7 up and coke down, with the facial nerve kind of on top and the cochlear nerve down on bottom within the IC. So if we do an axial cross-section through the midpoint or the lateral half of the internal auditory canal, we should see all these nerves separating out. This is the cerebellum, so that's the back, so this is anteriorly. So superiorly and anteriorly, that's where the facial nerve is within the IC. So those fibers all come together. So the cochlear and all their balance from the utricle and the saccule and each of the semicircular canals, they come together to form the vestibular cochlear nerve. And again, those auditory nerves are crossing over to the other side and then going up to the auditory cortex. So our balance nerves, we think about those 5 nerves. So the little inferior vestibular divides up into the saccule and the posterior semicircular canal, and the utricle and the superior and lateral semicircular canal ampulla are all going to the superior vestibular nerve. We used to think about the lateral IAC as this macula cribosa, it was often called, and we talked about it kind of being this perforated space where the nerves just kind of went through. But as our imaging gets smaller and smaller, we can sometimes see these little channels if you look in the lateral IC. So we can sometimes see these individual nerves. And we're living in a time where our technology is progressing so fast, we have to have the ability to learn, unlearn, and relearn not only anatomy, but imaging normal anatomy and imaging pathology. As our technology gets better, we're starting to see structures we couldn't see before. So again, here's the modiolus, the bow tie in the middle. It's populated by the spiral ganglia. They all come together to form the cochlear nerve that goes to the IC. On CT, again, here's that cochlea and the modiolus in the middle. There's that little cochlear nerve canal, and it goes to the internal auditory canal, and through the opening, or pores acousticus, the opening of the IC, laterally within the cerebellopontine angle, or CPA. We're going to see the cisternal and CPA angle cistern segments better on MR. Whatever CSF bright sequence you're doing, T2 weighted image, KISS, SPACE, Fiesta, whatever your vendor's CSF bright sequence is. So then we'll finish up in the last couple of minutes with the facial nerve. Facial nerve is a very complex course through the temporal bone itself with a lot of segments, and it have different functions. How many central cranial nuclei contribute to one seventh nerve, one facial nerve? So anytime we think about perineural tumor spread, we're thinking about imaging from the origin nucleus all the way out through the end organ. So we think about the midbrain. We want to start imaging behind the pontomedullary junction and kind of go out through the face. And we think about these nuclei as usually extending up and down in the midbrain. So how many central cranial nuclei contribute to one seventh nerve? Most of you said 3. Great, 37%. That is correct. So we have 3 main functions of the facial nerve. So it makes sense that we have 3 central cranial nuclei. Most of it is motor. The voluntary and involuntary muscles of facial expression are majority of what the facial nerve is doing. There's also some parasympathetic fibers, mostly going to lacrimation for tearing. And we have special sensory taste to the anterior 2/3 of the tongue with the chorda tympani. So where does the facial nerve exit the midbrain? It's a trick question, if you've been paying very close attention. Is it the upper pons, the lower pons above the pontomedullary junction, at the pontomedullary junction, upper medulla below the pontomedullary junction, or is it the lower medulla? Where does the facial nerve really exit the midbrain? Yeah, got about 150. What did most of you say? Lower pons above. Look at you. So most people say at the pontomedullary junction. That is traditionally what it's taught. It turns out, here, funny tidbit trivia for today, there was a German medical student in the 1700s who did a bunch of dissections and drew pictures of all the cranial nerves, and he just named them from the one on top being 1 going down to the bottom through 12, and he drew all these pictures. People have been replicating those pictures over and over again for centuries incorrectly. It turns out 7 and 8 actually come out of the pons above the pontomedullary junction, but people have been replicating his pictures over and over again, showing those nerves coming out at the pontomedullary junction. Funny tidbit. So if we think about a midbrain through the pons and where the fourth ventricle is, there are these two little bumps on the front. Those are the facial colliculus. The motor nucleus that's under that is 6. The motor nucleus of 7 is actually anterior and lateral to that. And those fibers do kind of a stupid thing. They wrap around 6 and then come out the pons inferiorly above the pontomedullary junction. And it passes in between the superior salivatory nucleus and the solitary nucleus. It joins those fibers and they all come out together from the pons itself out laterally. So we think about where the stria medullaris is and the little bump above that. If we cut out the back of the cerebellum, that's where 7 is. And this is one of those classic pictures where we see the pons and the medulla, and we see 7 and 8 coming out right there. They're often drawn incorrectly at this location. If you look closely, you see that 7 and 8 actually come out of the pons. So we should have named it 1, 2, 3, 4, 5, 7, 8, 6, 9, 10, 11, 12. So if anyone wants to go push forward to renaming all the cranial nerves, you go, girl. So we'll see that. I am out of time, so I will go ahead and hand over the lectern to young Dr. Phillips, who's going to talk to us now about skull base. Thank you very much.
Thank you very much, Dr. Wiggins. It is my pleasure to be, again, stuffed between two really excellent lecturers. I get to follow Dr. Wiggins and precede Dr. Curtin. So the pressure's on, so I'm going to just kind of chill out for a minute here. How you guys doing? Everybody okay? Good. What I would like to do in the next 30 minutes is talk to you a little bit about the skull base. How many of you really like the skull base? Show of hands. Well, a few. Skull base is usually where people, when they're reading head CTs, kind of turn off, and it's where people are reading necks kind of turn off because they're getting too close up to the brain. So for the next 30 minutes, let's concentrate on the skull base as if it is the most important piece of anatomy in the body. I have no pertinent financial disclosures, obviously not. We're going to talk about embryology a little bit. Again, by show of hands, who liked embryology in medical school? Okay, nobody. Yeah, that's right. We're going to talk a little bit about embryology and development of the skull base. We're going to talk about the foramina, a bit about the bones. That's kind of straightforward. We're not going to do much about that. We're going to talk about some normal variations that you may see in the skull base. And we're going to test ourselves, much along the lines of what Dr. Wiggins just went through with you. So, the embryology of the skull base essentially develops as these little sheets of fiber cartilage that ossify. So if you can imagine if sheets of cardboard could become formica, at some point it turns into formica as starting with these little sheets of cardboard. They get really firm and they ossify. So in the fetal and developing neonatal period, we have these little sheets of poorly ossified cartilage that develop in separate little metameres of development. So they're all kind of scattered around here in this sea of cartilage. They're all named. We're not going to do much about the naming here, but what I would like you to appreciate is that the bony development is by these sheets of cartilage. There are potentials for a lot of foramina between these sheets, but interestingly enough, most of the foramina actually develops central to each of the bony plates of development. Some of the foramen do develop from points of juncture of the bones, and that's going to become very important when we want to start thinking about the anatomy and what we're looking at. So we have essentially the sphenoid bone, the ethmoid bone developing in front, the basiocciput developing posteriorly. And these soon-to-be synchondroses, these where plates of this cartilage develop together, are very evident. And when you look at infants' CT exams, you can see that very clearly. But also, please remember that these are these potential sites for some of the variants that we're going to see and some potential problems. Looking at the floor of the skull, looking at the skull base, we realize that it's kind of segmented here, and this nice color amorphous graphic here kind of makes it very easy for you. But we're going to be looking most critically here at the frontal and ethmoid bones when we look at the anterior fossa, the sphenoid and occipital bone posteriorly, and Dr. Wiggins has also already gone through you in elegant detail the temporal bone. So on this sagittal examination, nice representation here of what we actually see, the floor of the anterior fossa, and this interplay between the sinonasal cavity and the CNS spaces. So frontal bone making up a small segment of that, the ethmoid bone behind it, the sphenoid bone, kind of this nice green coloration here with the sphenoid sinus and the sella, and the occipital bone posteriorly. That spheno-occipital synchondrosis is an important element we look for in development, and again, we're going to see some developmental problems at that area. Now, in talking about foramina, I have these little things I do with our residents and sometimes with the fellows when I'm looking through temporal bone exams or whatever. I just start pointing at foramina and asking them to name them. And it can be a little tense for a while. But there are some really easy rules to think about when you're dealing with skull-base foramina. And we're going to imagine that we all have some baseline information here. How many of you went to medical school? Okay. So we have some baseline anatomy information already in our heads. So we're looking at these little holes in the skull base. So realize as a radiologist, anatomy and your knowledge of anatomy makes you king. People come to you with questions about things because they know you're all over this stuff. Learn the normals and the accessory foramina, and every time you look at a skull base CT, a cervical spine CT, it's a chance to look at those foramina and just kind of hammer them into your heads. When I approach that and I'm thinking about the foramen, I think of the contents first. And then when I know the contents of that foramen, I'm already kind of 90% there. Foramina can be recognized by a very simple rule. That foramen goes from somewhere to somewhere else. And I just have to think of what anatomic structure needs to do that. So, just for an example, let's think about foramen ovale. We know that V3 lives in foramen ovale. And we know that V3 is going to carry motor drive to the muscles of mastication. So I need a hole at the skull base that will take me from where I know V3 lives down into the masticator space. So on a coronal diagrammatic representation, there's V3, and I know it's coming out the posterior aspect of the cavernous sinus, and it needs to dive into the masticator space. So I find on a CT examination a appropriately located foramen. I got foramen ovale, and there goes V3. It's very straightforward. That drives me right into the masticator space from the posterior cavernous sinus. On MR, and now I can actually see not only the foramen, but I can see V3 itself exiting as this nice little cord-like trunk with peripheral enhancement here, a little perineural enhancement at the foramen ovale. So think of the foramen in that regard. It makes your life a lot easier. So let's look at segments of the skull base, and we'll start with the anterior skull base, move to the central and posterior skull base. Our bony landmarks in the anterior skull base are going to be the cribriform plate, the roof of the ethmoids or the fovea ethmoidalis, and the roof of the orbit. Every segment of the skull base has cranial nerves and some vascular structures that are kind of critical to it. Very important in the development and also in what we're going to be thinking about pathology in that segment. Cranial nerve 1 is the dominant CNS feature of the anterior skull base, lying over the cribriform plate here. Again, remember the anterior skull base forms that interface of the central nervous system and the sinonasal cavity. So we have some foramina to deal with up here. So on this side, we have cranial nerve 1 kind of overlying the cribriform plate. We can see that there are some foramen at the skull base. So here is the plate of the ethmoid bone, the frontal bone lateral to it. There is a dehiscence between the frontal and the ethmoid bone here, the foramen cecum. More on that in a moment. The cribriform plate has multiple small holes kind of permeated for those little roots of cranial nerve 1 diving into the floor of the sinonasal cavity. So we can see all these tiny little fenestrations there. But we also have two vascular foramen, the anterior and posterior ethmoidal foramen, for small arterial structures. And again, please appreciate that they are at that junction of the frontal and ethmoid bone. So when we look at our cross-sectional imaging, we can see crista galli, and invariably on your axial sections, you will see a small defect, a small bony foramen, the foramen cecum. On sagittal reconstructions, you can sometimes see that behind the developing frontal bone and frontal sinus and in front of the crista galli. Now we got to do some embryology, and I apologize, but we're going to make this very painless. The frontal bone and the nasal bone are developing externally at about 4 to 6 weeks, and deep to them, the central nervous system is developing, and we're starting to develop the ethmoid cavity. At 4 to 6 weeks of development, there is a small diverticulum of dura that penetrates that space behind the nasal bone, just inferior and medial to this little dehiscence between the frontal and ethmoid bone, the fonticulus frontalis. It dives down into this space in front of the developing ethmoids. So S here represents the nasal capsule. That's going to become all of our ethmoid development. So that dural diverticulum kind of peaks down. It's down there for a short period of time. And at 8 weeks, it pulls back. And it does a couple of things as it pulls back. It takes a little bit of bone with it. That's going to become the crista galli. It's going to leave a small bony defect. And that's going to be our foramen cecum, again behind our now fused frontal and nasal bone and our ethmoid bone. So that's very important in development. That's a lot of potential areas for maldevelopmental states. When we look at our anterior skull base CT and MR, again, we can appreciate this interplay between the CNS spaces, the crista galli here, and the roof of the ethmoids and nasal cavity. We can see bilateral cranial nerve 1 here on this heavily T2-weighted coronal section. So here is our first question. So what we have in this patient is a frontal subfrontal mass, has some fat in it. It lies in the anterior skull base. In what foramen? While we're kind of just waiting for a couple answers to percolate in here, on the touch questions, I notice a lot of people are trying to drag the little crosshairs around. It doesn't work very well that way. If you want to move, you put it someplace inadvertently, just touch where you really want it to go. It'll work a lot easier for you. 170, 480, 315. Faster, faster, faster. All right, let's go. Foramen cecum, good. 95% of you. I had a really smart group in here this morning. Let's move back to the central skull base. Anterior skull base is pretty straightforward. There's some really unusual maldevelopmental conditions there. But the central skull base is kind of the central clearinghouse for cranial nerves and things in the cranial vault. It's everything posterior to the lesser wing of the sphenoid and behind the planum sphenoidale and anterior to the petrous ridge and the dorsum celli. Cranial nerves 2 through 6 are the central nervous system features of this portion of the skull base. So the cavernous sinus and the sella, situated centrally, are the major components. We're not going to deal much with cavernous sinus anatomy here, but we're going to look at just about everything else. So let's turn the skull around and let's look at that skull base anatomy from an external perspective. And we can see some foramen here. And again, developing within the plates of the bone, we have foramen ovale, foramen spinosum, the carotid canal, and if we look medially, we have this little area of bony development between the occiput and the temporal bone. At the anterior medial aspect of that area of synchondrosis is a little cartilaginous-filled foramen lastrum. And that development here along the petroclavial fissure back to jugular foramen is a very important landmark. I just want to kind of hammer that home for you. Now, when we look at the foramen in the central skull base, it has been appropriately called the Holy Land, with an E. Many foramen and fissures here. Cranial nerve 5 is kind of a nice landmark for us, and when we think of the foramen in the central skull base, allowing 5 to kind of be your guide is a reasonable thing. Now, we're going to look at all these, the optic canal, the orbital fissures, carotid canal, foramen rotundum ovale, spinosum lacerum, and the Vidian canal. But again, please note this very central role of CN5 and the very prominent foramen associated with it. V3 diving inferiorly, V2 moving anteriorly and inferiorly through foramen rotundum, and V1 heading up towards the superior orbital fissure. So, looking at the foramen, and I have the cranial nerves in on one side, they're absent on the other. The optic canal, medial and inferior to the anterior clinoid process, moving into the orbit. Our orbital fissures are concealed here. We're going to look at those again in a coronal plane, much better perspective. We have then foramen rotundum, again moving in almost a coronal plane, but that dehiscence moving anteriorly and inferiorly. We have foramen ovale, again a nice oval shaped, very conspicuously oval in configuration, nice to kind of pick that out. Foramen spinosum, just posterior and lateral to foramen ovale. And foramen lacerum, again that fibrous portion of the central skull base at the anterior margin of the petroclavial fissure here. This has been described as the lady's footprint, and it does seem very appropriate. So when you're looking at that skull base, and you see that kind of rounded configuration in the little, that oval configuration with a rounded configuration dorsolateral, think of a woman's footprint. It works out really well. High-heeled shoes here, foramen ovale and foramen spinosum. Now the orbital fissures in the optic canal, again, much better seen from a coronal perspective. So we can see the optic canal and we can see the superior and inferior orbital fissures. The inferior orbital fissure is very conspicuous on imaging, easy to see, filled with fat, not much else happening there. The superior orbital fissure a bit more complicated. Now when I think about this anatomy, it's very clear to me that's a boomerang. So I'm looking for that boomerang that is going to be just lateral and inferior to my normal optic canal if I'm looking at CT, or the optic nerve when I'm looking at MR. So here's our next touch question. I have stars for you here in the inferior orbital fissure, arrows pointing to the superior orbital fissure. I would like you to place a region of interest in the left optic canal. And I did throw left in, I didn't say either. Couple more answers. Quickly, quickly, please. All right, let's look. Wow, everybody was kind of everywhere. And I told you, I said left side. I did say left side. All right, good. So the optic canal, again, that conspicuous little foramen, and oriented in the axial plane, but I think much better and more conspicuous in the coronal sections. All right, our next question. There is yellow arrows, kind of like I'm helping you a bit here, showing you where the optic nerve is, living in the optic canal. I gave part of that away there. That's okay. There's a red arrow, red star there. What anatomic region is indicated by that red star? I really would like to have the Jeopardy music. That would be great. I can get Wiggins up here to hum it for me. Couple more seconds here. Good, so 78% of you said superior orbital fissure. And that's exactly right. It's fatty contained, and on non-contrast T1 images without fat suppression, it's very conspicuous. All right, another touch question. I would ask you to place a region of interest here in foramen spinosum. And again, I'm helping you, kind of put a couple others out on the images for you. Pterygopalatine fossa up in front, foramen ovale, there's carotid canal. Another moment or two. Faster, faster. Okay, let's see what we got. Good, so a lot of people correctly chose this from the lady's footprint, ovale in front, foramen spinosum back posteriorly. And I guess somebody didn't have quite enough coffee this morning, or perhaps too much. It is so hard. All right, another touch question. What foramen is indicated by the red star? I'll just ask you to kind of remember what we've talked about. And while you're looking around here, just nice depiction here of the Vidian canal, foramen ovale. We can see spinosum partially covered by my arrow. There's the petroclaval fissure for some help. And the carotid canal posterolaterally. Quickly, quickly. Let's see what we got. 85% of you picked the foramen lacerum correctly. I didn't get to see my indications there. All right, next one. What cranial nerve is indicated by the red star? Maxillary division of the trigeminal nerve, mandibular division of the trigeminal nerve, glossopharyngeal nerve, or the Vidian nerve? Another moment or two. Let's see what we got. 76% of you said trigeminal nerve, mandibular division. That's correct. Another touch question, or excuse me, another question here. Looking at a coronal CT examination, you can see foramen rotundum, superiorly and laterally, the Vidian canal inferiorly and medially. Classic relationship here at the central skull base. There is a nerve that traverses the Vidian canal. What nerve is it? Greater palatine nerve, trigeminal nerves, petrosal nerve, or the facial nerve? Let's see what we have. So 48% said the greater superficial petrosal nerve. That is correct. So the Vidian canal transmits a small artery, intermittent artery, the Vidian artery, which is a potential anastomosis between the distal internal carotid artery and the distal external maxillary artery, and the petrosal nerve, the greater superficial petrosal nerve. All right, let's cross now back to the posterior skull base. And I'm not going to be talking about temporal bone. You've heard that already. But let's just think about posterior skull base anatomy and the few foramen that we have to deal with here. It's everything posterior to the dorsum celli. It's the basiocciput and the basisphenoid, the clivus, all the craniocervical junction. The foramen here that we're going to be dealing with, foramen magnum, which I'm not going to talk too much about that. That's pretty straightforward. But we're going to talk about the jugular foramen, the hypoglossal canal. You've already heard about the internal auditory canal. Cranial nerves 7 through 12 are the dominant CNS features. And obviously through the foramen magnum, we have the exit of the brainstem. So let's look at the posterior skull base foramen of note here. So again, on our axial representation, we can see the cranial nerves on your left. On the right, nothing is depicted. So the jugular foramen again, and then we do that little bit of landmarks. Foramen lacerum, petroclavial fissure, back to jugular foramen. Very consistent landmarks and allows you to very easily identify pathology or to see those normal foramen. Remember again, the jugular foramen is at that plate developing between the petrous segment of the temporal bone and the basiocciput. Foramen lacerum filled with cartilage, we don't care about that too much. It does give rise to the name of the lacerum segment of the internal carotid artery going over it, but remember the carotid artery doesn't enter there. Jugular foramen, very important, posterior dorsolateral skull base. And finally, we have the hypoglossal canal. The hypoglossal canal is essentially a canal within a canal. If you think about it as a perforation of the occipital bone from foramen magnum into the superior aspect of the carotid space. And that's a nice way to get the hypoglossal nerve from the inferior brainstem into that carotid space just below the skull base. The jugular foramen has some relatively complicated anatomy, but we can break it down very simply in giving it two compartments, which are fairly consistent in our imaging depiction. We can see an anterior medial smaller compartment, the pars nervosa, and a larger posterior and lateral compartment, the pars vascularis. The jugular vein, the dominant component of the pars vascularis posteriorly. When we look at coronal anatomy, then we get a chance to make it a little bit easier for ourselves in terms of what we're going to see routinely. The bird's beak has been described as like, they're the birds of the skull that you need to look for, the birds in the body, and this is one of the more classic ones. The bird's beak here at the level of the jugular foramen gives us a jugular foramen above and a hypoglossal canal below. So finding the mass effect on the bird's beak can be very useful in depicting pathology and putting in a correct space for our surgical colleagues. Jugular foramen above, hypoglossal canal below. So again, thinking about that distinction from foramen lacerum back to the petroclavial fissure to jugular foramen, I can always find foramen lacerum and the petroclavial fissure. I know the jugular foramen will be posterior and lateral, and I can see the larger pars vascularis component and the smaller pars nervosa component. In coronal, both CT and MR anatomy, again, we see the bird's beak, and it's very consistent. You can look for it on all of your imaging studies. Remember the jugular foramen above, the hypoglossal canal below. Anything that erodes the bird's beak from below arises within the hypoglossal canal. Anything that erodes the bird's head, eyes, and takes the beak off from the top comes from the jugular foramen. On MR examination here, T2 weighted sequence, you can see actually the small hypoglossal nerve surrounded by a venous plexus and sometimes a little bit of CSF space. Easy to depict, you see it consistently. If you want to think about that relationship, I'll just show you on axial sections, it makes a bit of sense. The hypoglossal canal anterior in relationship to the jugular foramen. So here we can see on a post-contrast T1 the flow within the jugular vein, and on an inferior section the hypoglossal canal anteriorly, and again the hypoglossal nerve moving through it. And again, just kind of rotating back through that relationship, anterior hypoglossal canal, posterior jugular foramen. A few developmental anomalies, they can be relatively troubling, and people see them and they're not exactly sure what they're dealing with. There are thousands, and we're not going to do that here. I think it's very important to look at the cortical bone. When you have normal cortical bone, that's rarely going to be pathology. It's usually going to be a normal variation. They can be related to notochordal vascular remnants. So here is one. Instead of a lady's footprint, I kind of got a lady's footprint, but she's got two sets of heels. And that's not right. The one that is anterior and medially, the foramen of Vesalius or the sphenoidal emissary foramen, transmits a small vein, and it's a relatively common variant skull-base foramina. Here's another one that you'll see from time to time. This one named the fossa navicularis magna, a large defect in the basic sphenoid. You can appreciate this scallop defect. It typically contains just adenoidal soft tissue. Don't want to send people after that. It's kind of a leave-alone lesion. But again, please note this really nice corticated normal bone. Now this one can be a bit more problematic. This is a notochordal maldevelopmental condition. It's been referred to as canalis basilaris medianus. It has many variants and many potential appearances. This is a not uncommon appearance of this relatively uncommon lesion. A small defect posteriorly in the basisphenoid, and occasionally a through-and-through defect of the basisphenoid extending into the central nervous system. And again here, another canalis basilaris medianus. This defect that extends through and through, representing persistence of a notochordal remnant. Well corticated bone, we don't have to worry about that. Now this one is a little bit different. Now we have a defect actually in the skull base that's relatively significant. It seems to come from the sella. It extends down into the nasopharynx. Again, well corticated bone. This doesn't look like tumor or anything bad, but it is certainly a maldevelopmental condition. We know that would be where our pituitary gland is. We're concerned, so we're going to do an MR on that patient, and again we can see that there is pituitary tissue through that. This represents a persistent craniopharyngeal canal. Again, a defect occurring between those sheets developing in the presphenoid and base of sphenoid, allowing this abnormal development of the pituitary gland. It can be accompanied by other central midline defects. This is another important central skull base anomaly. You see this lesion, you see it not uncommonly. This is a common cause of people making a little miscall and patients getting sent for additional evaluation and surgical evaluation on occasion. Don't miss this one. This lesion looks kind of like a bubbly lesion of the basisphenoid. But note on the MR examination there is fat within it, and that fat's actually very important for me. You can look at the bone windows, you might be able to make that call just on your CT examination, but I find MR to be essentially a confirmatory examination. This has been described as the benign fatty lesion of the sphenoid. Some people call it arrested pneumatization of the sphenoid. So it's essentially an intraosseous lipoma. It's this maldevelopmental lesion with kind of arcs and whorls of calcification, but that presence of fat really makes the diagnosis. The appearance here is very similar to what people occasionally call hemangioma of vertebral bodies. So we've got some knowledge here of a few things, and let's look at a couple pathologic cases to close with and see how we've done. This patient presents with a numb chin and a prior history of an oral cavity squamous cell carcinoma. What is the likely diagnosis? Is this metastatic lymphadenopathy? Is this perineural tumor spread via the facial nerve? Is it perineural tumor spread by the mandibular division of the trigeminal nerve? Or perineural tumor spread via the maxillary division of the trigeminal nerve? Seeing a lot of green there, that makes me happy. Another moment or two. All right, let's see what we got. 92% of you said that was perineural tumor spread via the trigeminal nerve mandibular division. That's correct. And again, that course up into the skull base, we know where that hole's got to be. We can see the course of V3 extending up into the posterior aspect of the cavernous sinus. Classic depiction of perineural tumor spread, and a pretty classic history, that prior history of squamous cell carcinoma. All right, let's look at another one. This patient presents with a right vocal cord paralysis. During the course of their imaging evaluation, this lesion was located. What anatomic location is this lesion located in? Is it foramen lacerum? Is it in the jugular foramen, the stylomastoid foramen, or foramen magnum? Another moment or two. So when we think about this, we have that, again, that little coalescence of foramina along a synchondrosis, pointing us back to the jugular foramen. 77% of you got that correct. Very good. And our last case is in two segments. So I'll show you this image first from a CT examination. Axial and coronal image here. What foramen is widened and indicated by the red star? There are a lot of bird fans in the audience. Jugular foramen, hypoglossal canal, foramen magnum, or the condylar foramen? All right, let's see what we got. Good. 92% of you said the hypoglossal canal. That's excellent. So our final question here. This patient underwent an MRA. Here's the source image. What is the diagnosis? Is this an internal carotid artery dissection? Is this an internal carotid artery aneurysm? Is this a persistent trigeminal artery? Or is this a persistent hypoglossal artery? Let's see what we got. So 84% of you said indeed this is a persistent hypoglossal artery. Excellent. So we've talked a bit about skull base anatomy. We looked at some cases. We looked at some foramen. I again encourage you to test yourself on normals every day. That's kind of part of the fun of being able to sit at the view box and kind of like keep stacking up that knowledge in your head that you've seen this before and you know exactly what it is. Account for the normal structures and it makes it a little easier to assess for involvement of the basal foramina when you're looking at pathology. Thank you very much for your kind attention, and it's my pleasure to ask Dr. Curtin to come up here to the podium and get him started. Dr. Curtin?
What do I do now? Start.
Just hit the space bar. Look at that screen. You can just hit space bar to advance.
Okay.
Or click on that arrow on the bottom right.
Oh, this thing. Oh, this thing.
So if you want, you can hit space bar just to advance.
All right. Very good. Thank you, Doug, Rick, and Debbie. I appreciate the opportunity to talk to you a little bit about the larynx and hypopharynx. And we're going to go through some anatomy and hopefully navigate through some of these structures. And we're going to try to do just a few things. Number one, we'll pick out structures that will help us navigate throughout through the larynx when we're looking at imaging. We'll also point out a few things that really make a big difference at surgery. So we'll throw in a little bit of pathology. And then finally, maybe talk about a couple things that I think are curious, but you may not. We'll see how it goes. But this is the endoscopic view of the larynx. And now everything that we do with imaging in the larynx, we're now going to be looking with the thought that the surgeons may be, number one, they're going to go in and they're going to look at all this mucosa, so we're not really responsible for that. But we're going to be thinking along the lines of the patient may be undergoing endoscopic surgery. And so they're going to go in, they're going to need us to tell them about some of the deeper areas. This is what they see with the epiglottis. This is the false chord, the true chord, aryepiglottic folds. And here, piriform sinuses, that's what they can see. Here, these are some of the things that we can see. This is a 3D image of a specimen larynx. You see the thyroid cartilage, the cricoid coming way up in back, coming down a little bit lower in the front. And you can see what I think is arguably one of the most interesting joints in the human body, the cricoarytenoid joint. We'll talk about that a little bit. So this is the cartilage, this is the mucosa, and what we're really going to be talking about over and over again will be the soft tissues and the various walls of the larynx. And so we'll go through this. But for now, remember false chord and true chord, and the first question is what structure separates the true and false vocal cords? Is it the ventricle, the aryepiglottic fold, the piriform sinus, the vestibule, or the subglottis? Getting close, sneaking up. A little faster, faster. All right. That's long enough. The ventricle, absolutely. That's probably the most important structure in the larynx. And a lot of what we're going to do is talk about how we're going to be able to find it so we can describe lesions relative to this little slit-like structure, which is the ventricle. And 49% of you got it right. But this is, if you take away 1 point, it is how to find the ventricle. All right, this is the laryngeal ventricle, and this is an endoscopic view with the true chord, false chord, and this is the slit-like ventricle that goes right between them. The embryology above is different from that below. The lymphatic drainage, different above and below. So again, the surgeries change at this point, at this level, and so that's why the ventricle is so important. But this is what they can see. They can actually take an endoscope, go down and look laterally into the ventricle. You have the anterior commissure up here. You can actually see the arytenoids in the back wiggling a little bit, and we'll get to that. But here, notice the true chord has some significant bulk. It isn't just a thin wire. And so the next question is going to be, what muscle is it that is going to make up the bulk of the true chord? So what muscle gives you that bulk? So here are our choices: the glossolaryngeal, the thyroarytenoid, the posterior cricoarytenoid, the sternohyoid, or the cricothyroid. Now, most of these are indeed muscles somewhere in the larynx. Not all of them. But the most important one, this is going to be the one we're going to ask you to remember because, again, this is going to help us navigate. It's going to help us find the ventricle. So that's one of the reasons that it is so important. So we got enough. If we can get you up to 250, we'll consider it a game. Anybody, go for it. Very good. All right. It is the thyroarytenoid muscle, and most of you got that right. So again, the thyroarytenoid muscle is a fairly sizable muscle, and it actually makes up the bulk of the true chord. This is the thyroarytenoid muscle. It goes from the thyroid cartilage to the arytenoid. The medial fibers are called the vocalis, but taken together, it's the thyroarytenoid muscle, and it's easily found in the axial image. Here is the cricoarytenoid joint. These are all structures right at the level of the true chord. And so if we are trying to say where the ventricle is, then this thyroarytenoid will help us get to it. It'll get us to the chord, and we know the ventricle is immediately above that. So thyroarytenoid muscle is considered really the navigator muscle. It is what will tell us where we are, and so this is where most people start. It's triangular in both the coronal plane and in the axial plane. So thyroarytenoid muscle. Now the next one is a touch question. Use your cursor to indicate, or pointer, the paraglottic space on either side. Now while we're guessing those of you that aren't clicking, I want you to put your hands up. If you notice, the one that makes an L is your left hand. So it should be helpful, any of these are that are going forward. However, that does not work in axial CT. That's why we allowed you to have both of these, either one. I'm going to have to go a little quicker. 130, 150, we're getting close. Paraglottic space. It's not a great name, but we're going with the classification that was originally described by Tucker and Smith, talking about a certain area that becomes very important for us both to navigate and also it is a major situation dealing with endoscopic sinus or endoscopic laryngeal surgery. All right, that's close enough. Let's see how we did. All right, and you could have been on either side, and a lot of you got it. Here's that same person wandering by. I think as they snore or sort of drift in and out of sleep, they might hit their cursor. All right, but the green is the paraglottic space. People call it paralaryngeal. I think paraglottic is probably the best way to talk about it. It's simply the lateral soft tissues of the wall of the larynx. But it's important. It's a route of spread, and it also helps us navigate. This is the true paraglottic space. It's bounded by the conus elasticus and the quadrangular membrane. It's good to know that they are there, but it really does not figure into our diagnosis, these membranes, but they do limit tumor spread. But notice this, that you have fat above the ventricle and muscle below, so that's going to help us find this particular structure. And as I said, the paraglottic space is one of the most important routes of spread for us to look at because there's no way that they can really pick it up by just looking into the larynx. So in the histology, here is the thyroretinoid muscle. So fat to muscle transition tells us where the ventricle is. And then when the muscle disappears, you can think of this as being glottis and subglottic. Now you might argue paraglottic is not a great term. You can use just lateral soft tissue wall of the larynx, but remember, it changes abruptly at that upper edge of the true chord. So here is the ventricle right there. How do we find it at imaging? Well, you can use the cartilage. Remember, the cricoretinoid joint is going to help you, but it's really the soft tissue that will guide us at imaging because it is really fat to muscle, and that is the exact point of change. The cartilages are close. They'll show you where the true chord is. You may be able to figure it out from there, but this is indeed an important transition. Now here is the preepiglottic space. It tends to get more press, but it's really the paraglottic space that I think is the more important one for us to know about, or at least it's important to know it. It is how we navigate. If it's fat, you're above the level of the ventricle. Here is our marker slice, so this is right at the cricoretinoid joint, thyroretinoid muscle, so you know you've made the transition here, and then the subglottis, so it's fat to muscle to nothing, supraglottic, glottic, and subglottic, and remember the transition of fat to muscle. Here we can see the ventricle, but you can see above it's fat and below it's muscle. And here, even a little bit further back, it is, you don't see the ventricle here, but you do know exactly where it is, and so that's how we are going to describe various lesions that are occurring in this space. So navigating paraglottic space, incredibly important. Now this is how we describe tumors. So if you see fat, you know the tumor is above the level of the ventricle. Here you see it's below, and here it's going down into the subglottis. So fat to muscle with our marker slice, thyroretinoid muscle, cricoretinoid joint. This is the upper part of the cricoid. That may be important later. And here it's down into the subglottis. So this is transglottic as it's crossed over the ventricle. Remember that term refers to crossing the ventricle, not necessarily the cord, but this one went all the way down into the subglottis. Now, a lot of tumors are supraglottic and some are at the cord, but the ones that go into the paraglottic space often tend to arise right at the ventricle, because they're not facing this imposing quadrangular membrane or conus elasticus. They can grow right through and infiltrate this paraglottic space, and from there it can actually leak out and become extralaryngeal by going between the thyroid, cartilage, and the cricoid. So paraglottic spread, something for us to look at even if it is a relatively small tumor, particularly if there's a bulge in the mucosa. Now this particular case, you'll notice, is this one was actually thought to be relatively small, but the clinician, when they looked in with their endoscopes, said there was a supraglottic bulge, and look how it's come down, filled this entire space, and escaped out between thyroid, cartilage, and the cricoid. This is actually not much of a barrier. Some of the other things are, but if it can get through into the paraglottic region, it can leak right out extralaryngeal. We'll get back to this. All right. Now we have a pointer question. Indicate which shape is closest to that of the arytenoid cartilage. Now some of these images you may have already seen. We may have discussed these earlier on. Those of you that are Canadian, I apologize in advance because one of them does look a little like Quebec. I'll let you guess which one of those is correct. All right. We can get up to 250. We'll let you off the hook. Any last votes? All right. Well, this is it. This is the arytenoid, and it does look a little bit like Quebec, I presume. But all right, let's look at what some of these other ones are. This one, Rick's already shown you. This is indeed the incus. You can see its particular shape, very characteristic, and I hope none of you guessed that. This one, to get back to our bird analogy, is not actually a diving owl, but it's actually the sphenoid bone. This, anybody get this or guess what this is? Argentina? No, it's an island in Lake Erie. Just happens to be a place that we go right down here, right by Putin Bay. But I don't think any of you would have guessed that. But here is the arytenoid, and this is, I think, we put the corniculate on it as well a little bit, and sorry about some of you, there is a little bit of a soundtrack, but here is the arytenoid sitting up on top of the cricoid, and actually you can probably come up with just about any shape that you want just by rotating it around. And here's the vocal process right here, and actually the arytenoid slides up and down on its little facet. Getting tired of the noise, so we will move on. Here is the arytenoid. Here is the vocal ligament, vocal process, corniculate. This is actually the cuneiform. I want to thank Jim Kobler for helping me with these dissections, which can be translated, he did it, I watched. And here is the cricoid, and here is this little arytenoid perched up, not in the midline, it is actually offset just a little bit. All right, our next question. The arrow points to part of which cartilage? Is it the arytenoid, the thyroid cartilage, the cricoid, or the corniculate? You guys can vote faster than that. Very good. Now we're picking up the speed. We'll cut you off at 250. All right. C is the answer. Now this is an important point. Not everybody got this, and so we're going to go through this just a little bit because this is a common mistake and we want you to be able to avoid it. So here is partially from Netter, modified a little bit, but the arytenoids do not perch right up in the midline. These little bumps are actually part of the cricoid, so don't mistake them when you're looking at trauma. Is this got something to do with a dislocated arytenoid? This is a young person, and so the arytenoid is just not that well mineralized, but it's sitting off a little bit on this arytenoid slide, if you will. There's a little bit of a facet on the cricoid that the arytenoid will slide back and forth, but the back of the arytenoid, really, its base, never really reaches midline. It's off to the side. And here, if you rotate it out, you still see those little bumps. So it is part of the cricoid cartilage, not the thyroid, that's here, not the arytenoid, and this is a little bit more lateral. So here is the cartilage, and here is that joint. Here is the facet on the arytenoid. This is the vocal process. We've rotated it a little bit. But the arytenoid slides up and down here, and this little bump right on the edge of the facet, if you will, of the cricoid is that little place. And it does get mineralized not infrequently. So it's an important thing for us to know. This is where the arytenoid articulates. It slides up and down. Here, this is the arytenoid. You have the corniculate on it. And here, if you cut into the joint, you can see that entire joint. It can slide and it can rotate front to back. So it's an important, very interesting joint. It probably has more muscles attached to the arytenoid than probably most other joints. Most of the laryngeal musculature does. But we can open that joint up, and it's important to know it's a little bit off midline. And so the cricoarytenoid joint, if you just look at it on a few of the next images, take Doug's advice and just look at a little bit of the anatomy, you'll know where it is. It's important for partial resections of chondrosarcomas. That is the most important thing they will ask about. Here is the arytenoid, here is this chondrosarcoma, and many of the people at our institution will do a partial resection, as these are very low grade. But they want to know where is it relative to the joint. And here you can see it coming right up to the cricoarytenoid joint, which is, as we said, just a little bit off midline. So you have to know where it is if you're going to describe it in chondrosarcoma cases. This is another point that Roberto Moroldi from Brescia talks about, this is an area right by the arytenoid, close to the gap between the arytenoid and the thyroid cartilage. If you have tumor that makes it back here, it's almost impossible to get a malignancy out of that area, this little area tucked inside. So the cricoarytenoid joint, extremely important landmark. Just back here, when you see tumor, we describe lesions specifically relative to this. Now, they may design a way to get into this. We have some people working on that, but currently this is a big problem if the lesion gets into that little sulcus. All right, getting down to the end. What borders the piriform sinus anteriorly? Is it the esophagus, the paraglottic space, the conus elasticus, the interarytenoid notch, or the thyroid gland? Is it directly abutting it? All right. Voting away. We're up to 135. Does the red mean that these are incorrect answers? Yes, sir. Uh-oh. I see. So we'll have remedial larynx anatomy immediately following. All right. Well, let's get at least close to the midline. I mean, how embarrassing could it be? You know that the person next to you got it wrong. So, all right. The answer is the paraglottic space. Remember, there are certain things we're stressing, and so the paraglottic space is one of them, so you can almost guess that's what the answer is going to be. So 47% said that, so that's actually pretty good. The paraglottic space is a concept that we don't usually learn right away, but here is the piriform sinus, and here is the supraglottic fat, and there's really almost less resistance to get into the paraglottic fat coming this way. There is no big, thick membrane. And so here you see the tumor, Here is an old 3D image. Here's the piriform sinus. Here's the arytenoid, caniculate. Here is the cricoarytenoid joint. And if you go through that mucosa, you end up in the paraglottic space. And it infiltrates. This one went all the way down to the cord. Because of that, we actually describe lesions that are in the lower pharynx and piriform sinus. We always will note the relationship or the level, again, based to the ventricle, based to thyroretinoid muscle, and particularly looking for infiltration of the paraglottic space. Here you can see it looks very much like a lesion coming from the ventricle, but no, this was infiltration coming from the piriform sinus. All right, now this one's tough. Mark the ventricular appendix. This is tough because it's a small area. We had to make the target bigger, a little bit bigger, just so that it would register. So the ventricular appendix. Now we talked about the ventricle being that structure, separating the true and the false cords. But the ventricle, we'll give you a hint, extends up from that. Some people are getting close. I guess filling half the screen with the target volume did help, Doug. So we've got two levels. This is the true cord level, the cricoarytenoid joint, and this is the supraglottic level. And actually, we might give you part credit if you marked one other thing. That's hard to mark. All right, is that enough? People are starting to get it wrong. Well, actually, I was going to give you credit if you marked this little dot. But not many did, so that was, but this is the ventricular appendix. So what is that? Here is the ventricle. The appendix is just a tiny little tube that goes up superiorly, so it's supraglottic, paraglottic, bringing everything together. It just is lined by mucus glands to really put a little bit of irrigation to the true cords. That's what it's for. But if it blocks off, it can fill with air, it can fill with fluid. We like the terms air-filled and fluid-filled laryngocele, but a lot of people will say laryngocele is only air, saccular cyst means it's filled with fluid, but air and fluid-filled laryngocele, you're never going to be misinterpreted. So here is the ventricle. Here's this little channel, which is the appendix. Now, this patient had been radiated, so here indeed you have a laryngocele, and you always, when you see a laryngocele or saccular cyst, you've got to look for a tumor down at the ventricle, and here this patient does have one. But even if you don't see it, they have to, the clinician has to go in and look for that themselves. So here is the saccular cyst or laryngocele. Here, because of the radiation, this little ventricular appendix is shown up just a little bit better with a little bit of air, and actually you did pretty well with that. All right, last question, and then we're just going to go through the anatomy quickly one more time. What is the only abductor of the vocal cords? And here is a hint, because I can never remember. I had a friend named Abe, but he moved away. So that may be totally unhelpful. And actually, I did have a friend named Abe, but I actually moved away. That doesn't help you either. All right, is it the thyroretinoid, the thyroepiglottic? Is it the interarytenoid cricothyroid or posterior cricoarytenoid? And the little yellow light came on my timer, so we better move on. All right, let's see how we did. All right, the posterior cricoarytenoid muscle, absolutely. Now here's the posterior cricoarytenoid. It's this little bit. Here's the cricoid. It's down a little bit. The cricoarytenoid pulls the muscular process back. Here's the thyroretinoid. That pulls it somewhat forward. Here, lateral. You can see it rotating. This is the cricoarytenoid, but the lateral one. This pulls it again. Cords go to midline. Interretinoid, same thing. It is the posterior cricoretinoids that will abduct, make them move away, the vocal process when you're trying to take a big, deep breath. And there again, the cricoretinoid joint. So that is, you can see that on the back of the cricoid with a vocal cord paralysis, but most of the things are really because the thyroretinoid gets so small, the ventricle gets big, and so that's the real thing most people usually see, but we like to emphasize here's normal, this is fatty infiltration of the cricoretinoid posterior. So if we start at the top and go down, here you can see the paraglottic space, aryepiglottic folds, here's the ventricular appendix, here's the cricoretinoid joint with our magical navigator image with the thyroretinoid muscle, the joint, and the cricoid. Keep going down, you see the pharynx, and here it turns to a round structure when it goes down to the esophagus. So these, I think, are the key landmarks. Ventricle, the upper edge of the cricoid, and the cricoretinoid joint. We describe absolutely everything in the larynx relative to those structures. The piriform sinus, again, we still describe lesions there relative to the anatomy within the larynx. And don't forget, the paraglottic space is simply the wall, and the fat to muscle transition marks the ventricle. Get used to what is the normal appearance, and it'll help you when you're trying to analyze some of these images. So thank you for your time and attention, and I think Rick is going to come up.
Okay, as with everything else, don't leave. You have to be present to get the trophy. If you want the sharp, pointy thing that TSA will take away from you. Looking at the scoreboard, the winning team is the Bears. The Bears pulled away by 1,000. If you are on the Bears team, we can't actually check, and you want a ribbon, just come up to the front, and we'll give you a ribbon. For the players, you have to be present to, excuse me. Nada Sanghead, are you here? Nada, come on up to the front, you're the winner. We have 3 trophies. Second place, Sarit. Are you here, Sarit? Did you come? Were you cheating? You were sitting right next to her. Tell the truth. No, go to Doug. He's got your trophy. Come on up. Second place. Third place, Hillary. Where's Hillary Kelly? Hillary, woo! Okay, thank you guys so much for playing. Hope you enjoyed the Rapid Diagnosis Live Rapid Fire section. Please fill out your evaluations. Hope you enjoy the rest of the conference. Safe travels home. Thank you.